Bhavya, it has gone live. Let me just cross post it. Bhavya, it has gone live. Bhavya, we can start.
Okay. So good afternoon, everyone, and welcome to our session Unsung Heroes. This is the 12th session, and as always, we always would like to welcome our unsung heroes, our optometrists who are tirelessly working in the community eye health department. So I would like to introduce our optometrist today, that is Mr. Mahendra Singh we have, and we have Mr. Rashad, and also we have Ms. Ramla. So, to brief you about Mr. Mahendra Singh, he is a PhD scholar at Tirthankar Mahavir University in Moradabad, and he also holds bachelor's and master's degree in optometry from Chitkara University, Chandigarh. He has completed a 2-year fellowship at LV Prasad Eye Institute, specializing in low vision and rehabilitation. He has also served as consultant optometrist for vitreoretinal diseases at LV Prasad Eye Institute, Hyderabad. He has also specialized in low vision and rehabilitation management at LV Prasad Eye Institute, and currently he is working as faculty member and consultant optometrist at TL Gupta Eye Institute. And next we have Rashad. So Rashad has completed his master's in clinical optometry from Amity University, Gurgaon, and bachelor's from Malabar College of Optometry. Currently, he is working at Ahalia School of Optometry as assistant professor, and he also has a 2-year work experience at Sharpside Group of Eye Hospitals, New Delhi. Next, we have Ms. Ramla. Ms. Ramla has graduated bachelor's in optometry from Era University in 2020 and has completed her 1-year internship at Indira Gandhi Eye Hospital, Lucknow. Currently, she is working as academic tutor at Era University. Along with that, she is also pursuing her master's from Chitkara University. We welcome all three optometrists. And now I would like Mahendra to introduce himself if I have left out on something.
So good afternoon, everyone. And myself, Mahendra Singh, and I'm working as a faculty and consultant optometrist at CL Gupta Institute, Moradabad. And recently I'm pursuing my PhD from Tirthankar Mahavir University. This is placed in Moradabad. And I'm working basically in the low vision department along with the teaching. We have B optometry school and we have the intensive program at CL Gupta Institute. And in our institute, in daily basis, we have around 400 patients OPD. And this institute is affiliated from LV Prasad Institute to Hyderabad. The same pattern we are following as the LV Prasad Institute is following. So my role is here to in academic as well as the low vision department and the diagnostics. Thank you.
Thank you, Mahendra. Over to you, Rashad. you introduce yourself?
Okay, myself Rashad ibn Muhammad, working currently as an assistant professor at Ahalya School of Optometry and Research Center, Palakkad in Kerala. And I currently work as an academician rather than a clinician. I'm an academician now. And previously, I worked in Sharpside Center as a clinician, as a consultant optometrist at New Delhi in Swasthya branch. And now I am basically taking care of UG and PG optometry students and their trainings.
Okay.
Yeah.
Yeah, thank you, Rashad. Ramla, would you like to introduce yourself?
Yeah, I'm Ramla Akhtar. I completed my bachelor's from Mera University, and currently I'm working as the academic tutor there, and I manage all the season screening camp, school screening camp of school-going children, and for organized by Mera University and Dia Foundation. So thank you, OCI, for giving me this opportunity. It's a pleasure to connect with you all. Thank you.
Thank you, Ramla. So this session is very special to us as we have 3 optometry institutions, faculty who are connected with us for our various projects that we conduct, including community eye screenings and also our 2 major projects, that is Vision for Cause and also the geriatric outreach and ocular disease, that is Good Study. So to begin with the session, I would like to start with the questions as usual to first to Mahindra. So Mahindra, would you like to share your experience about treating community patients in the low vision department?
Yes, sure, ma'am. And thank you, OCI, for giving me this opportunity to share my experience with you all. And hope you will get benefited and some sort of encouragement from my experience and with the short talks. So basically, I'm working in low vision department along with the academics, and I'm pursuing my PhD also in the low vision departments. Because we have the special subject in third year low vision, and we read about it and we complete and we passed about the low vision. But when I joined at the CL Gupta Institute, I have seen there is a lot of patients, like 4 in 100, that we cannot treat or we cannot manage these kind of the patient with low vision devices or any kind of medications. We cannot treat them with any special lenses. So then I decided to move in the low vision department, and I started the low vision clinics or along with the low vision kids, and I got the referrals. And the daily basis we have around 5 to 10 patients in average OPD. And in our experience, like the 70% of the patients, those who visited to the low vision department, they get benefited and they are very happy, and even they can continue their if the patient is children, or if the patient is adult age groups, or if they are not able to continue their official task, or they are not able to continue their daily functionality, so at least they can continue. So according to my experience, the low vision, it's really helpful and impactful for those who have non-avoidable blindness.
Thank you so much, Mahindra. I hope you see patients from the community department in your low vision department as well.
Yes.
Right?
Yes.
So would you like to highlight on how different is it to see community patients in your low vision department?
Yes. As you know, we have 2 type of the patient here, like urban and in the rural area. So in the urban, the majority of the patients, we have less number of the patients because they are already known. They are already known and they are taking some sort of the treatment, or they are managing their own task, or they are managing with their functionality with the help of their friends, family members. Even they have good help by their families. But those who are poor and the community, and especially in the remote area, they have very poor support by their families, or even they are sitting at home and they are doing nothing. If we take that kind of the patient and we treat them, or we give them some sort of the like glasses or if somehow they can be able to continue their task with the help of low vision devices or the spectacles. So it means it's make the changes in their life. So according to my experience, the 70% of the populations from the remote area and the community area, they get benefited from the low vision department and the low vision services. So it is not necessary that we can give only the low vision devices, or even we can give them counseling, or even the counseling also is boost their knowledge as well as their confidence also. So it's very necessary for the, like not in the urban people, those who are rural peoples, we have to catch up them. The community people, they get benefit from the low vision department and the services. So this is my experience for the like rural area people and the community people.
Thank you, Mahendra. My next question is to Ramla. So Ramla, what instruments and how do you handle instruments at community screenings?
And we basically carry all the instruments we need to remote locations by the transport they allow from the college or university. So it's easy to handle because we don't carry all the instrument is like slit lamp and all, just basic instrument, and then we carry the patient to our hospital if they have any issues, or we refer them to the base hospital.
Okay. Also, you would be doing a comprehensive eye health examination when you're there at the camp, right?
Yes.
Okay, Ramla. So my next question is to Rashad. Rashad, can you share your experience about the school vision screening that we are conducting?
We all know that the early detection and treatment has a very important role in eliminating the avoidable blindness and visual impairment. So we from the Ahlia School of Optometry was keen to doing all these rural area school screening programs for I think last 4 to 5 years. We have been continuously doing that, and from the last 2 years with the partner with the OCI and Aloka, we have been doing the VFC program as well. So what we do is we separately select a group of area or a particular area to where we have a rural community as well as the urban community as well. So we separately select the rural community to go there and check the vision there, and we give spectacles for free with the help of VFC, and that's what we usually do right now. So we all know that the vision and learning has it is a parallel line. We cannot disturb anything or the other, because in the first 10 years of age or 1 to 10 years of learning, the vision is crucially important role in academics. So we try to improve the vision of the students who are we try to improve the academics by improving the vision. So what we do is we go there and have school. What we do is we initially we take a permission. It is very difficult to have a permission from the government school to have an ice cream. It's very difficult. So what we do is we have to go around to the schools and the DMO, the district medical officers, and then district collector. Everyone. There is a lot of politics in it, and we have to go around a lot to to access to get the permit for conduct a school screening. And we usually goes with the first years, second years. We include everybody: first year, second year, third years, and PGs as well. So we give each an important role to each and everybody. Like for first year, they are the one who is taking care of all the equipments, all the they are the caretakers of students. Second will be the
sorry to interrupt, Rashad. So how many of you go as a team when you go
as a
for
team? We mostly go around 30 students. Yeah, 30 students
for
and
a
3 to
camp?
4 faculty. Yeah, for a camp.
Oh, That's interesting because accommodating all the 30 would be a difficult task.
It is very difficult, but it is very, it is very fun for us. Like when we only go with 1 or 3 students, it is won't be that much interesting for the students also. But we go in a
Okay.
group, it is very easy and very fast. It's very fast. And it is fun also because we'll be having a lot of students and everybody will be looking at how much it is very fun
Yeah.
actually. So we go there and most of the second year female students, they're taken care as a vision takers or history takers, because most of the students have a little bit afraid of the male students. So females will be more compassion about the vision. So we will we ask them to take the vision for them. And third years will be the one who is monitoring all of them. PGs will be the one who is going to do the refraction, confirm the refraction by which is done by the third years. And we usually won't involve with the interns because interns will be mostly busy with the hospital.
Okay.
And the faculties will be there if the PGs have any problems with it. So the faculties will be there to consult for that.
So I hope a lot of learning and enjoying happens.
Yes,
at the
yes.
camp
That is the
site.
reason they in Ahilya, everybody, when there is a camp, they will always ask, sir, when is our camp?
Okay.
They're very keen to know because that's what happened. Now everybody is learning together with their
Okay.
hands on and everything. So it's very, very interesting actually.
Okay, thank you, Rashad. So my next question is for Mahendra again. So Mahendra, would you like to share your experience about encouraging students to learn retinal diagnostics?
Yes, sure, ma'am. As you know, nowadays, like we are basically focusing on the refraction part. And as you know, as an optometrist, so we are good into do the refraction, but many of the diseases that we cannot like correct with the spectacles or correct with the refractive error correction. So for this, we need some sort of the retinal investigations. So if we are good into read it or interpret it, so that will be good for us. So at least we should have some sort of the basic idea how to read the OCT and how to read the other investigation like fundus photograph. And after seeing these fundus photographs, that we can make out that the vision will not come out perfectly, or even we can explain to the patients properly the prognosis of this disease. So suppose I am taking the example of the retinitis pigmentosa. So everybody know about the retinitis pigmentosa and the prognosis, but maybe the patients don't know. But if we refract the patients, so somehow we get the refraction, or we can dispense the glasses, or even along with we have to explain to the patients that the vision will not come out the proper, or maybe over the period of time it can deteriorate whatever the vision you have. So we should have some basics knowledge at least. So as an optometrist, so if we are performing or examining the patient or counseling the patient, because if we give the glasses and somebody also giving the glasses, or even the good centers where they have a specialty, even they are doing the same things. But as an optometrist, as we are primary healthcare practitioner, so if the patient have some investigations, so we can take them or we can interpret them, and if we have good time, so we can explain to the patient also. So that is the initially time, so we can take the patient in the belief, or they can trust you who you are. So at least we should know like at least OCT or fundus fluorescein angiography or the fundus photo, or another than other investigation like pentacam, Hope scan, corneal findings. So we should know, or we have to increase our optometrists and the futures upcoming optometrists also. So that I would like to like say and give the message to everyone. So those who are enrolling themselves in the optometrists and doing internship, so at least they should have some exposure of the retinal diagnostic also. So
I'm sure even your students will have a different approach when they actually read in the classroom and then see it while they're handling instruments, right?
yes, even we do in our clinic also. We have slit lamp and other accessories. We have ophthalmic accessories in our clinic. So if somebody is doing the refraction, so we have all the accessory to reflect the patients. So the major things we have retinoscope. So all the students, those who are doing intensive, so in the intensive, we teach the patients how to do the retinoscopy along with the slit lamp examination. So if the patient is not able to read the 20/20 or N6, so they have some sort of question in their mind why the vision is not coming. So we are allowing our student also to do the 90-day examination, so at least they can see the posterior pole. Or if the posterior pole is okay, so it means even they do repeat the refraction. So even the vision is not improving, then we dilate the patient and see why the vision is not improving. So we have the culture here to see the like posterior segment and to see the posterior segment interpretations and why the like vision is not improving. So at least they can get some idea or they know why the vision is not improving. So the equivalent to the ophthalmologist they are doing in our places.
Okay, thank you, Mahendra. So my next question is to Ramla. So Ramla, how do you encourage students to take up community eye health services?
Ma'am, as Rashad sir told, we also aim to engage all semester students in camp so that this way they all are engaging and they learn from right from the beginning. If we engage all students, so that first year student will take demographic data and history, and the second year will focus on vision screening, and then third year will do all the various performing all the tests. So that's way we are encouraging and students, and at another way to get them motivated and excited, we have a tradition. It's like कि जब हम लोग कैंप से वापस आते हैं, so that is कि जो भी फैकल्टीज इन्वॉल्व होगा वो उन्हें ट्रीट देते हैं, एंड इन द आफ्टर रीचिंग द कैंप एंड तो उन्हें ट्रीट जिसे भी ट्रीट देना होता है जो भी फैकल्टीज इन्वॉल्व होते हैं, और मतलब ऑन द वे ये एक्टिविटीज में एंगेज होते हैं, लाइक अंताक्षरी एंड फन गेम मिमिक्री, एंड ऑल्सो दे डोंट नीड टू गेट मोटिवेटेड एंड encouraged, they are always getting enthusiastic by participating in camp, so they all are always eager to get part of the camp. We don't need extra motivation to encourage them.
So we have Achyuta and Era who are spoiling their kids by giving treat and everything. That's really nice to listen. My next question is for Rashad, wherein Rashad, what are the challenges that you had experienced or faced during the geriatric screening in the old age?
Basically, we know that the area of the geriatric area is very difficult actually. The patients have most of the geriatric old age homes have major condition is a psychiatric disease rather than any other thing. The basic thing that they do, everybody has is a psychiatric. They are very lonely, they're very depressed, they are very anxious about everything. So to taking care of them is very much difficult. Rather than a small child, they are very small children actually. The geriatric group, we cannot say that they are older age students. They are very small, very small already adults. So they have very very small, what do you call it?
So though they are a geriatric age group, they are similar.
Even though they are aged, they are not mature. Yeah, that's what.
Yeah.
It is very difficult for them to have. And second thing is they take a lot of medication other than a single one or two medication. They have multiple medications. So that is also one of the issue where we focus. We have an issue where whether we should do another kind of treatment or so, because most of them are using psychotic medication. So the people will be very small. The people will be too small so that we cannot see even the reflex also in the retinoscopy. And most of them have a dementia. When we ask them to look there, they will look somewhere else. So having Alzheimer's disease, they won't focus at the same time. They will lose focus in a second. They will lose focus, and they will be when you ask for history, they will tell something else. Their family history, like they have a son or something like that.
Yes, yes.
We ask for a small question also, they will distracted to somewhere else, and they will be always complain about their own things. So that's it is very difficult to engage a patient of geriatry into a ophthalmic exam in the camps. But in the hospital, it's completely different because we have all the sophisticated instruments and everything in the hospital, but in the camp, it is very difficult. It is one of the things I got easier is to get the permission. It is very easy to get permission for the, because nobody is going to come there. Nobody is, they are very lonely actually. Nobody is coming and they want to have a checkup, but they couldn't do that. So whoever is volunteering to check up their eyes or who whatsoever, even for the mental checkup also, they are very acceptable. They are very free and very easy to get accepted in that.
Okay. Thank you, Rashad. My next question is to Mahindra again. So Mahindra, what are the challenges that you have faced while evaluating the low vision?
Yeah. So whenever we have the patient in low vision department, so the major issue is like already they have spent a lot of times in the institution and some OPDs and ophthalmic checkups. The major problem is like when we call the patient and take the patient in the low vision department, and they have the like diverse and the different category of the vision loss. Some of them they have peripheral vision loss and the central field loss. Some type of scotomas they have. So in the routine OPD, as we check their visual acuity, we know we have to ask the patient to look straight, but we have to review all the procedures. So what is the diagnosis of this patient and where the scotomas they have. So according to them or according to their requirement to assessment, we have to change our position as well as our like setup instruments and the visual acuity examination. So this is the first thing. And the second things, we need some special type of visual acuity examination chart as we have in our clinic logma chart. And for them, we are not supposed to check the visual acuity like count to finger 1 meter, 2 meter, or CF. So we should have the different kind of the low vision chart. That's called the BRBT chart. So some of them even they are not trained. Suppose if I am absent, along with me, there are 3 or 4 more optometrists, those who are working with me. So suppose even if they are not there, so it means the optometrist and another optometrist, even they don't have the more interest to examine the low vision patients because this takes so lot of time, so approximately 1 hour. Or even the end of the 1 hour, the patient denied if we give some time of the devices, or like if I say low vision devices, or even if we do the counseling, because they know they have gone through all the investigation and many of the doctors, they said nothing can be done. But in the low vision department, we are very like aggressive and knowledge and experience we have, or even according to the scientific base, we said if you are not having the good vision or poor vision, but as a normally you can do. So the acceptance rate for the community people or basically the poor people is very low. So for them, we need more counseling rather than giving some times of the management. So the major challenges is assessment of them. And the second, even they have the economic problem also. Because it is correlated to each other. If somebody is having poor vision, so they have some financial burden also, and they have some cognitive problem also, understanding problem also. So these are the some like barriers and problems, or we can say the barriers in our examination we have in when we examine the low vision patients. So these are the issues we have.
I'm sure even sometimes language also can be a barrier, right?
Yes, if somebody having the poor visual acuity, so they are not directly in contact with the community also. So they are not good in to touch how to talk with others also. So this is again the correlating to each other. So those who are poor visual acuity for the past sometimes at least 5 or 6 years, so they have the language barrier also. So these are all the issues we have. Yes.
I agree with the one more thing also that you had mentioned about how time consuming the entire provision evaluation itself. So the patient is drained off already with the evaluation itself, and at last they're not interested, right?
Yes.
So how do you motivate again these kind of patients? Again,
Actually,
counseling would help, is what you say, right?
Yeah, counseling, and we the second person we have the EMR, electronic medical record system we have in our institute, and all the data we have, or even we do the manual recording also in our institute. So if the patient is already, we know the low vision devices and the low vision services definitely would help to these kind of the patients. So again, we call them, their family members, and ask them, and the follow visit of the low vision patients in our institution is free of cost. We never charge these kind of the patients. So, and we explain them, or even the one more phase we do for the visual impaired patients. We recommend them to get the blind certificate also from the government hospitals, because if the somebody having a poor visual acuity less than 6/60, so according to the government scenario or they are eligible to get the blind certificate.
Benefit.
So simply we ask them to get the blind certificate, or even they get some pensions. So this is the all the regions we are contact with the patients, or even if they get the blind certificate or they are getting the pension. So this is again the positive thought and the positive trust toward the patient side. They came to us and asked us, is there any more benefited we can get? So again, we can take the patient for the mobility training, or as well as for the visual impaired. Our institution have the one more project that is called the ICNE. So all the visual impaired, those who are young, but only the disabilities, only the visual related disability, we take them and we teach them how to, like in this Raksha Bandhan festival. So we teach them how to make the Rakhi, and in the festival, we teach them how to make the diya and the candles or candies and all. So these are the good things. We take the patient in the favor. So these are all the things we do.
That's great to hear. Even you take up skill-based programs for low vision patients,
Yes, we
which
do.
actually helps them economically and financially.
Yes.
Thank you so much for shedding light on this, Mahindra. My next question is for Ramla. So Ramla, what challenges do you face during the community screenings? I know the fun and learning is happening, but again, definitely there would be some challenges. So what are these challenges that you had faced?
The main purpose of school children screening का कि जो भी उनका vision related issues है हम उसे early detect कर लें ताकि हम long term उसके visual impairment को रोक सकें. तो एक incident I want to share with you कि एक हम लोगों ने screening किया था from at 10 to 12 kilometer distance or from my university at Kakuri. तो वहाँ पर the infrastructure and everything देख करके मतलब you can't, it's hard to believe that this is a government school, everything. So and जब मतलब हम लोगों ने पूरा स्क्रीनिंग परफॉर्म किया एंड ग्लासेस डिस्ट्रीब्यूट किए, जब फॉलोअप के लिए विजिट किया तो जो मतलब जो प्रिंसिपल थे वहाँ के, उनका उन्होंने इंट्रोड्यूस किया एक स्टूडेंट्स से कि इंट्रोड्यूस किया कि ये स्टूडेंट, यू कांट बिलीव कि ये स्टूडेंट बहुत शांत रहता था बिल्कुल क्लास में, एंड आफ्टर गेटिंग स्पेक्ट्स मतलब ही इज परफॉर्मिंग बेटर. एंड हियर उसकी जो भी एक्टिविटीज में पार्टिसिपेट करने लगा, बहुत सारी वेरियस एक्टिविटीज में. सो ये है कि ये विजन रिलेटेड इशूज जो इतना छोटा लगता है किसी के लिए, ये इतना मतलब चैलेंजिंग हो सकता है, और ये इट्स रियली हाईलाइट द इम्पैक्ट ऑफ सिग्निफिकेंट इम्पैक्ट इन मेकिंग अ डिफरेंस इन these such camps to screen such students.
It's nice to hear, Ramla. We always learn from the patient satisfaction and testimony, and it always encourages us to do more. I definitely agree with you. And my next question is for Rashad. So Rashad, what are the challenges that are faced during the school screening and also the community?
Previously I said that the major challenge for the school is permission. Permission from the district medical officer, we need to get the permission, and after that from the school itself, because school always have in every standard, they always have exams, they have one or other exam or test or something like that. So they think that if we conduct a camp, it will obstruct their studies, obstruct their regular activities or such. So some of the schools were very reluctant to how many hours you're going to take for camp, how many hours the students will be here for the camp. So will the students may miss this this hour of this class? So everybody is worried about it. They are just taking one day or 1 hour in one class, maybe 10 to 15 minutes. But the schools or the teachers think that we are taking more time, or they think that we are obstructing their teaching or something like that. Second thing is, I have seen in the government schools that the students are not coming in regularly. So we are always missing few students whenever we go to the camps. So what we did was, in the first camp we had that mistake. So whenever we directly went there without, we directly informed the HM only, and we headmistress or the principal only, and we directly go to the camp. But on that day, there were so many students who were absent. So to cover up that thing, so we in the next camp onwards, we already informed all the teachers. So we asked them HM to inform all the parents to inform all the parents that we are conducting an eye examination in there, and they will get practical. That's how we got that better more than 700 or 600 students for 2 days. That's how we screened. And third thing, the myths around the spectacle. That is a major concerning one actually. And maybe because of they had an experience with the non-professional optometrist or non-professional optician from the past, they won't believe anybody. They only believe one hospital, either one opticals or one hospital, one major person that they like or the parents like. So whoever gives the spectacles free, they won't wear it. They will wear only those from the respected institute, whether they said, then only they will wear. Otherwise, they won't wear it. And even if there are some parents who doesn't like their children to wear spectacles, even though they know that is going to hurt, but they were said no, it will be over. It will be minified in after any age, a certain of age. It will, they don't need to wear the specs, but that is one of the issues that we faced in the school screening camp. And in the geriatric screening camp, what we faced was
like you already shared the patients having psychological conditions.
Psychological issue. So most of them are ready to have it, but the thing is that in that old age home itself, they are confined actually.
Yes.
So very much confined, that they don't want to do. Everybody in the old age home has a separate jobs actually. So one of them will be in the kitchen, one of them will be in the gardening, one of them will be for any handicraft activities. So everybody has a certain things, and they won't read anything. They won't read newspaper, nothing at all. They just sit on their bed and they live their life like that. So it is very difficult to convince them to wear the spectacles or go for a cataract surgery, go for something like that. So even one of the myths in the older generation is that when they have a highly cataract stage or a white fluorescent cataract or something like that, or a very mature cataract, they think that it is from the God itself. They got punished because of the something like that. So that is also one of the major thing that we cannot remove it with we have to have a constant counseling for that. But anyway, they are on psychotic medicine, so we cannot completely eradicate that.
Okay. Thank you, Rashad. My next question would be for Mahindra. So, Mahindra, what is your message to optometry students who would like to take up low vision as their specialty?
Yes, even in our institute, we have the intensive program in our institute, and many of the students, if I say more than like 20% students, they are put into the low vision examinations as well as to dispense the low vision devices, right? So like we can have some real life stories. If the patient is coming to us and there is no treatment is available, and the patient is sitting at home doing nothing, so we can take these kind of the patient real world stories, or if the patient is happy, so we can take this story in front of the students, those who are pursuing or try to get knowledge in the field of optometry. So we can show them the real world stories, or if the patient is happy, so it means they will get some type of the encouragement. And the second things, we have to do the hands-on session, how the low vision devices will work and how the low vision devices is effective, and what is the benefit and indications and like contraindications of the low vision devices, and how we can dispense the low vision devices. So even if they are masters and the skills in how to dispense the low vision devices, so that is also the one points to give them encouragement. And hands-on session, and every month we do some kind of the awareness programs in the morning class along with the doctors and the optometrists and the students, and the daily we have the morning class, and every month we have the class related to the low vision. So what is the basic referral criteria of the low vision, what are the cases you will manage with the help of the low vision devices, and what is the basic referral criteria. Even in our institute, if you will ask with any student, those who are pursuing the internship, you can ask them what is the cause of the low vision, what is the cause of low vision. So they will tell you, and they will tell us. So even this is the one more thing, we can skill them. If we will skill them, what is the cause and how we will manage them. So this is again one more point, we can give them encouragement. And according to my experience, when I came here in the 2015, and every year we do the seminars, and seminars purely related to low vision. And previously in the every years we have low vision awareness program in LVPI. So constantly we do, and this was the 10th low vision awareness program we did in our institute, and we got maximum delegate related to join the low vision only, not in another conference. So in our auditorium capacity is 150, but the last year we got the application 200 around. So it means the people are learning to about the low vision, because even though they know, even they have some barriers. So what are the barriers they have? Even I have done some sort of the study and published. So these are major of the things is lack of awareness, or awareness in the terms of in the diagnosis, in the terms of how we can manage them and how the low vision device is effective. So the major issue is awareness. And if we will remove these things, the awareness barriers, so definitely they will get the encouragement to them. So these are the things we do, and we are supposed to do. So, and we should tell to our student also, like how they can dispense the low vision devices and how it is impactful, or even how you can dispense these kind of the low vision devices to the patients. So these are the things we do, and we got the good response. Or even the some of the faculty is came to us, and they are in my contact. They are keep continuing referring to me these kind of the patient, or even the basic things they do. They are doing the low vision practice in our area. So basically, I am from Uttar Pradesh, and we have low vision referral in our area. So these are the things I would like to say to everyone.
Thank you so much, Mahendra. Sorry, I think I got lost. Um, yes, definitely. Along with students, when we see the patients, it makes a lot of difference about how we encourage them to take up low vision. We do have a few questions. So my question would be for Rashad about so what difference have you seen within the students' behavior after they have attended these BFC study and the good study camps?
Okay, so even though they got curious about all the camps, new camps, when they were, they were interested in doing camps. First of the thing is, second thing is their technical skill got improved. Like the way of, taking care of the patient, the way of doing this, tests and everything. They got to know that what is normal and what is abnormal. They get to, they got to improved communication skills to between the patient, and their knowledge getting developed.
Yes, definitely. And I also agree with the communication that you said. Ramla, would you like to add anything to this question?
Yes, ma'am. The difference is between all this type of camp and VFC camp. Before VFC camp, as per VFC guidelines, we have to train this camp before students को train करना पड़ा, so that they can't confuse between pass and fail before the camp. And the जो normal camp होते हैं वो तो easily they perform कर लेते हैं, but इसमें ये है कि थोड़ा सा confusion होता है pass and fail, and then they are actively participating.
Okay, so definitely training is necessary before the students go out to the camp, and maybe the performance also would get better after the training, right?
Yes.
Okay. Thank you so much, all of you. Any questions? Sakina and Kashada ma'am, do we have any more questions?
No, Bhavya, that's it, I think.
Okay. So thank you so much, Mahindra, Prashad, and Ramla, for taking your time and participating in our session today. We would like to be connected with you for more sessions. Thank you so much.
Thank you,
Thank
OCI,
you.
for giving this opportunity. Thank you, ma'am. Thank you.
Thank you.